Okay, class, we almost got through part one of the concept of perfusion, but we still have about 10 more slides. So I'm going to go ahead and make this video so that we can continue on and complete that presentation. So we were talking about cardiac output, and it equals, as we said, heart rate times stroke volume. But if we looked at stroke volume closer, we see that there are three factors that affect stroke volume. And so we had discussed preload and we had discussed contractility. And then the third factor that we wanted to finish up talking about was afterload. As we explained, the afterload is the amount of force that the left ventricle must exert in order to open the valves and move the blood forward, okay, in the circulatory system. So this is where we left off. Frequently, this pressure in the aorta and the peripheral arteries that the left ventricle has to work against to get the blood out is referred to as resistance. How much resistance the ventricle has to overcome to pump blood out to the body. Okay, and afterload is affected by several different things, okay, including the size of the ventricle, the wall tension. For example, how compliant are the walls of the ventricle and the blood vessels, or are they stiff and hardened? Also, another factor that affects afterload is arterial blood pressure, and that's the one that we gave as an example, and it's shown here in the slide with the black arrows. Okay, but there are other things as well, and so one of them that we talked about was cardiac valve disorders that can affect the amount of pressure or resistance that the left ventricle must overcome in order to move the blood forward. Ways to decrease afterload are to give your patient a vasodilator. Okay, and we talked about that in terms of our nitrates. Nitrates are vasodilators, and as we said, they cause widespread vasodilation throughout the body, meaning that the finite amount of circulating blood volume is increased out there in the body, meaning that less is returning, less volume would be returning to the right side of the heart. And that is a benefit to patients who have heart failure because their left ventricle is already so very weakened that it cannot move the blood forward. So we don't want to give them additional volume to pump around. Instead, we would like to give them less preload and less volume, less stretch, so that they don't have to, the left ventricle doesn't have to work as hard. So indeed, blood pressure or high arterial pressures can increase the amount of force that the left ventricle must exert. However, I want to caution you that afterload is not equivalent to blood pressure. They are two different things. There are many things that affect afterload, and high arterial pressures are just one of those things that increase the amount of force that the left ventricle must exert to move the blood forward. So don't make the mistake of equating afterload equals blood pressure. The two definitions are not the same, but certainly high blood pressure can make it more difficult to move the blood forward. Okay. So our arterial vasodilators, such as nitrates, we have things like nitroglycerin, nipride, which is another word for nitroprusside. These are nitrates, and they decrease afterload. And they do that through increasing stroke volume and cardiac output. Okay. So let me repeat that. Ways to decrease afterload are to give your patient a vasodilator. Okay, that is one way to decrease afterload. We can also decrease afterload if the patient has high arterial pressures or hypertension by administering an antihypertensive. Okay, by decreasing the pressure in the aorta, and therefore the heart will not have to work as hard. It will not have as much pressure to pump against. As a result, the cardiac output will go up. So indeed, antihypertensives such as ACE inhibitors in our hypertensive patient will lower or decrease, I should say, afterload. Okay, it will decrease afterload and therefore promote cardiac output. It should go up. Nitrates are used quite commonly in our heart patients, cardiac patients. They have different mechanisms of action depending on if it is a low dose or a high dose of the nitrate that is given. So low doses can, as we see in this picture, decrease preload, okay? And high doses can decrease afterload, okay? Whether it's low or high dose, both of them are going to improve or decrease the demand that the heart muscle has for oxygen because the heart is no longer working as hard. So that's another big plus there. And finally, the nitrates also work on the coronary arteries. They cause vasodilation of the coronary arteries. That's very positive because it allows better oxygen supply to get to the heart muscle. So there are many different ways in which the nitrates can improve cardiac functioning. This is a review slide about preload and afterload. Okay. First, we'll review the definition for preload. It is the amount or volume of blood, or we can say the amount of stretch in the ventricles at the end of diastole. Remember, the end of diastole is when the chamber is the maximum in terms of fullness. There's the maximum volume and the maximum stretch. The end of diastole is right before the chamber contracts. Okay, so preload is the amount of stretch, the volume of blood, or the amount of pressure. So they can use any of those terms to describe preload. And what type of conditions do we find increased preload in our patients? Certainly our patients in heart failure, we see that at the bottom. Heart failure patients struggle with increased preload. So anything we can do to decrease the preload for them is going to allow them to have a more efficient pumping action of their heart. Other conditions where we have increased preload include patients with hypervolemia, also those that have cardiac valve disorders, especially incompetent valves that don't close properly. These people end up with increased preload. So in all of those cases, we would want to decrease the preload to help their heart to beat more efficiently. Now we look on the other side of the slide and we have afterload. Again, that's the resistance that the left ventricle must overcome in order to move the blood forward, resulting in blood circulation. In what type of patients or conditions do we find an increase in afterload? Well, certainly our hypertensive patients fall into that category. And any patient who has vasoconstriction going on in their body, especially, peripheral vasoconstriction and vasoconstriction in general, which we can find in various disorders. So again, we can decrease afterload. It would be in the patient's best interest if we could decrease the afterload, and that would improve the cardiac functioning, because the left ventricle wouldn't have to overcome so much resistance, and it would make it much easier to pump and move the blood forward. In that case, it also reduces oxygen consumption because the heart is not having to work as hard. Now, the term ejection fraction, abbreviated as EF, is defined as the proportion of blood that is pumped from the left ventricle with each heartbeat. Now remember, we do not want a ventricular contraction to end up with 100% ejection of the blood. If we did that, the walls of the myocardium would stick together. It would be very hard to fill that chamber again if we ejected 100% of the blood. That is not the intention. Normal ejection, or proportion of blood that's ejected, is greater than 50%. Okay, so any number greater than 50%, some text or literature may say 55 or 60, but it doesn't matter. Anything over that is good. The problem we see is when it is below 40%. Okay, that is what we see with our patients who have heart failure. Remember, heart failure is a big boggy heart with an overstretched left ventricle and a thin myocardial wall. It is very weak. Okay, it cannot eject the blood from the left ventricle. So it ejects less and less, way below 50%. And that is very characteristic of heart failure. In fact, commonly, an ejection fraction of 25%, the patient is going to demonstrate difficulty, shortness of breath with activity. In other words, this is, I know from personal experience, seeing patients who have ejection fractions of 25%, they will have difficulty walking out to the mailbox in their front yard and back without becoming short of breath. Okay, they may have difficulty even walking around their own home from the bedroom to the living room without being short of breath. Now, in the hospital at Tampa General and in other hospitals that have a cardiac transplant unit, we see a lot of patients with even ejection fractions less than 10%. Okay, even less than 5%, yes. And these patients who have very low ejection fractions will struggle even to speak, because speaking requires more energy and oxygen than they have. So an ejection fraction of 5%, we can find these patients in the intensive care units waiting in bed for a new heart, because their heart is failing so badly that if they exert themselves in any fashion, it causes them to be short of breath and to struggle. So they are waiting. Their only last hope at that point is for a heart transplant. And there, that tells you how you could calculate the ejection fraction, but we don't ever calculate it. What we do is send the patient for an echocardiogram, and with the echocardiogram, it's non-invasive, it doesn't hurt. They just use sound waves, and they can come up with a good estimate of the patient's ejection fraction. So typically that'll come back with that report. We can also do other diagnostic tests to get a more accurate ejection fraction on a patient. But just understand that it does have a very direct relationship to the ability of that person to perform daily activities. Now, we should discuss this term cardiac reserve. It refers to the heart's ability to quickly adjust to immediate demands placed upon it. Okay? The maximum percentage that the cardiac output can increase above normal is called the cardiac reserve. In the normal young adult, the cardiac reserve is 300 to 400%. Okay? For example, running to catch a bus would cause an increase in oxygen demand, which must be balanced by increased blood circulation. This increase in cardiac output is achieved by an increase in either stroke volume or heart rate, or both. In the athletically trained person, cardiac reserve is occasionally as high as 500 to 600%. But of course, this is not what we see in our patients, right? Well, in our cardiac patients, that is not at all what we see. Our cardiac patients do not have cardiac reserve any longer, okay? Normal cardiac reserve in non-athletic persons is approximately 4 times their normal cardiac output. But in the weak or elderly person, it may be as low as 200%. So when you get to the cardiovascular ICU and our patients are struggling because they have cardiac disease, they do not have any reserve left, okay? They cannot, their heart can no longer respond to any exertion, let alone a strenuous activity, okay? It can no longer adjust the cardiac output to help the patient, right? And this is the state that we are dealing with. I just want you to realize that so many of our patients, especially our cardiac ICU patients, they don't have reserve any longer. So that's something to keep in mind. And then also understand that there are certain conditions that our patients can also experience when they're hospitalized, and our cardiac patients as well. So do you understand that when a patient has a fever, that is a hypermetabolic state, and they are going to need more oxygen, and they're going to depend on their cardiac reserve to provide those increased demands. So when you take your cardiac patient who gets a fever, and you understand that they don't have a cardiac reserve to meet any extra demands, and then you give them a fever, and then your patient is in a struggling state, and certainly in distress. Okay, I just want you to be aware of that. This slide brings up the point that we can increase cardiac output by increasing the heart rate and or the stroke volume. We know that from the calculation, the equation as it is stated. But we said before that this is only up to a certain point. The heart rate can increase to 180 beats per minute for a short period of time. Okay, so yes, the heart rate can increase to improve cardiac output, but only to a certain point. Like here they tell you 180 beats per minute. As we said earlier, when it's beating this fast, there's no time for the ventricles to fill, and so then we actually have a decrease in cardiac output. So if the heart rate is this fast, it cannot sustain life. Okay, so only can sustain it for a short period of time, not a long period of time. That's why we need to intervene and bring down, maybe use an anti-arrhythmic agent, but we have to bring down that heart rate. We need to get it under control because it is not consistent with sustaining life. All right, and that's all because of the effect it has on the cardiac output. Okay, when the cardiac output decreases, that puts the patient in a very precarious situation. Okay, they cannot perfuse their body, and again, that can be life-threatening situation. There are quite a few age-related changes to the heart, and I'll go through a couple of them here. We've touched on them before. But even looking at the heart's pacemaker system that controls the heartbeat, some of those conduction pathways may develop fibrous tissue and fat deposits. The pacemaker can lose some of its cells, and these changes may result in a slightly slower heart rate in our older adults. We also can see a slight increase in the size of the heart, especially the left ventricle. This is not uncommon. The heart wall thickens, so the amount of blood that the chamber can hold may actually decrease, despite the increased overall heart size. The heart may fill more slowly as well. So normal changes in the heart include also the deposition of calcium deposits, and the muscles themselves, those cells degenerate slightly. The valves inside the heart, which control the direction of blood flow, can become thicker and stiffer, and we can see the development of a heart murmur because of those stiff valves. Especially this is quite common in the elderly. The receptors called baroreceptors monitor blood pressure changes and can also make those adaptations to help maintain a fairly constant blood pressure when a person changes positions or activities normally. But as we age, the baroreceptors become less sensitive, and this can explain why many older people have orthostatic hypotension, which the blood pressure falls when a person goes from a lying to sitting position or from a sitting to a standing position. So they may experience dizziness because of this. There is less blood flow to the brain, resulting in that dizziness. So there's all kinds of changes that occur naturally as patients, as people age in general. Now I added just 2 additional slides here because your classmates had some really good questions regarding, we talked about genetic changes, especially with women. And age is part of that. At a certain age, a woman goes through menopause, and as a result of that, she becomes deficient in estrogen. And it is that loss of estrogen that plays a role in some of these age-related changes in women. And some of these changes are critical, and that's why we wanted to bring up some of these increased risks that are associated with estrogen deficiency, including coronary artery disease, which is one of the exemplars that we will be studying. In addition to that, there are some other cardiovascular signs and symptoms of estrogen deficiency, including a decrease in their good cholesterol. So that's the HDL, and you see a decrease in the good cholesterol, and we see an increase in the bad cholesterol, which would be our LDL. So these things are occurring in women as they get into the perimenopausal and postmenopausal stages. And these changes, which really set the stage for their increased risk of developing coronary artery disease. So we had a good question as well, why don't we just give them some hormone replacement therapy to give them that estrogen that they're lacking? And of course, that has been a therapeutic option, and it was for quite a while. But then the studies came out and showed that hormone replacement therapy, whether it's just estrogen alone or if it's used in combination with progesterone, it will increase their risk for other things that they don't want, such as breast and endometrial cancers. Okay? In addition, they saw an increased risk for developing blood clots. So what this means is that we have to be very careful in evaluating the risks and the benefits of using hormone replacement therapy in our postmenopausal or perimenopausal women, because there are, of course, very much symptoms that are not undesirable symptoms as women go through this losing their estrogen levels that are very unpleasant, is the word I was looking for, such as hot flashes. And so you might be thinking that, well, we'll just give you some more estrogen and then you won't suffer with these hot flashes, and that's true. But we really don't want to expose women to this, especially unopposed estrogen. That means estrogen all by itself, because it will lead to, it could possibly lead to breast cancer and other very life-threatening problems. Other cardiovascular effects that I'll just put here on the list that came from your textbook are heart attacks. Okay, so by giving oral contraceptives as well, this is not just hormone replacement therapy for postmenopausal women, but also oral contraceptive pills for our childbearing age women. So both of them can lead and have cardiovascular effects. And one of the prominent ones is thromboembolism, which is the blood clot formation, okay, or DVTs. And also can even lead to heart attacks, strokes, and hypertension. So you see, it's really going to be a decision that the provider and patient will discuss and look at the risks and benefits, or even how long they want to use those treatment options, because certainly by decreasing the length of time that they're using them, that will decrease their risk of some of these effects.